Hello, everybody. Just gonna keep letting some folks in and give everyone a minute to get themselves settled. Okay, everybody. Happy Friday. Thanks everyone for being here and promptly and making time on a Friday for all of this. I am going to put hopefully a copy of the agenda in the link in the chat. We're having some technical difficulties at CCI. So hopefully, if you have Outlook, I believe you'll be able to open that. But if you need me to resend it for any reason, I'm happy to do that as a backup. I was thinking we'd probably forego introductions today. Just please make sure your name and your organization is in your Zoom box square. And maybe just as you're speaking, be sure to introduce yourself. So first off, I wanted to leave some time and follow-up discussion on House Bill 1038, the Children and Youth Implementation Plan, and the HCPF Medicaid System of Care Settlement Agreement. I know Molly Bradley from CDHS is either in the car until 2 or is going to be joining us at 2. So I think we'll just kind of hold off on that portion until she is on and available. Just so everyone knows, I have spoken with our state partners about providing a written update on all 3 of those items, which they're willing to do on a quarterly basis. Thanks, state friends, for being willing to do that. But I do envision leaving time on our agendas each month, just as questions arise or folks have any follow-up they'd like to do, or if the state has any more smaller kind of in-between updates that they would like to share on any of those 3 items. Sorry, I'm out of breath. I went outside right before this and it is hot. So with that, Robert, I see you first. So I don't know if you have anything that you'd like to share on the Medicaid system of care.
Okay, sure. First I want to thank all the counties that have been helping with us get stuff scheduled. We'll be traveling a little bit this summer. I could put the sites up if I could share.
Katie, I think he's waiting for you to give
Oh.
permissions.
Yeah, sorry, I thought that's what you were
sorry,
doing.
share your screen. Sorry,
Yeah.
I'm sorry. I thought you were putting something in the chat. Try now.
Okay. Perfect, thank you.
Yeah.
And so, uh, this is the preliminary plan. Most of these are scheduled and are being worked on as far as placement. There'll be an official release next week on notifying everyone these dates, times, locations. I'm just working on a couple last locations. So we'll be traveling a lot in August. And then we'll have some virtual meetings. And I think it's a good group to talk to about. One, really was hoping to have meetings as it relates to metro counties virtually and as it relates to rural counties virtually, understanding that the challenges and limitations of services are different in those areas. So that will probably be sometime September. So I can work with you, Katie, and Heather on getting those scheduled. The family and youth one will be led by Mental Health Colorado, and we're contracting with them to facilitate 2 virtual meetings and then probably 1 in-person meeting with families and youth. So this the stakeholder schedules, and this is sort of the launching to review the system of care model that's being proposed with the plaintiffs and getting feedback. Any questions on this? It's about 90, it's gonna be about 90 minutes per meeting.
Robert, is this something we're able to go ahead and share more broadly these dates?
Yeah.
Okay.
Yeah. You can share this. I'm working on, I think the only place left I have to work on a location is Lamar and Burlington, and I have emails out, so.
Will your team be sending information in advance so that people can like come to the meeting to provide feedback, or is it kind of on the fly, just be ready to talk?
Be ready to talk, and then you'll have a chance to take it with you and provide feedback after as well.
Great, thanks.
Yep.
Katie, I'm sorry, I'm stumbling to try to find my hand raise feature, but when have I ever done that in person? So I'll just pipe in if you don't mind. Robert, thanks for hosting these stakeholder meetings. I know that there's a fairly tight turnaround. I believe it's February that the settlement plan is due in place, and then you have 4 years to implementation. Certainly, people are working on that settlement plan now. Can I be typically nosy me and ask if we can get a peek? Because it would be nice to be able to have something in advance to be able to comment on what's going on at those stakeholder meetings.
Yeah, so what I plan to do is present the model, which is what the plan, basically, the core of the plan. You'll have a chance to take the model back with you, mull it over, and then we're working on some kind of electronic, then we'll have follow-up meetings. I'll have a follow-up virtual meeting to answer any questions later as well. So I want to first have a chance to articulate the model, then give you a chance to digest it, and then have a virtual meeting to follow up. And we can use the metro and the rural county meetings as that meetings to do some of that follow up.
As you work on that, Robert, just let me chime in with my opinion, even though you didn't ask for it. Here's my opinion on that. I have found, with due respect for their kind folks at the state, when you get, for example, a settlement is most likely going to, it's going to involve multiple agencies. And I found that when we have a state model that encompasses multiple agencies, they'll ladder up in their agencies, but there's never sort of any sort of connectivity at the top. At CBMS, we have the Executive Steering Committee, which is a good way to ladder up into an organization that coordinates the work that goes on between the departments. Some sort of governance structure or accountability structure like that is going to be really important to counties to see, so it doesn't, the work is done oftentimes individually in the separate state departments, but sometimes that interconnectivity is a difficult thing. That's important to Weld County anyway, to make sure that there's some sort of accountability structure there that coordinates between departments.
Yeah, so we do plan to have three committees. 2 of these are outlined in House Bill 1038. So we do plan to have a state leadership oversight that will include county commissioners. Be invited. We'll have that set up by October. And that will be for the life of the project over 5 years.
Go ahead, Heather.
I have two questions. One I just threw in the chat. Will the BHA be closely involved, Robert, in traveling with you or hearing the feedback on the Medicaid side of the system of care concepts? And then I have a second one after that.
Yeah, so we hired Summer Gathical to facilitate the meetings. So her and I will be doing the traveling. She'll summarize the feedback. The BHA is on our leadership committee that meets every Friday. So they'll be provided all the information and feedback so that they're kept up to speed as well.
Thanks. And the second question is about the timeline in 1038 for the system of care rules. So I know HCPF has their own rule process for the system of care on the Medicaid side. And that seems very closely tied to the settlement agreement, stakeholder sessions. And then BHA has their deliverables around having rules for the rest of the system of care for populations outside of Medicaid, including who's eligible and all those kinds of things. So if the BHA's rules are due October 1 of 2024, but you all are just launching this stakeholder process on the Medicaid system of care side this month. I'm just curious how you're going to work together around that timeline and kind of what the initial rules will look like for system of care across both of your agencies.
Yeah, I'll let Matt talk, but my understanding of system of care rules for the BHA have to do with C1MHDA because that's the only funding source for system of care for non-Medicaid kids. So we are working very closely with them, particularly on high fidelity RAP and standardized assessment. But I don't know. There you are, Matt.
Yeah, no, I had to find, I'm not used to Zoom again. So usually I'm on Google. But anyway, yes. So we definitely have, make sure that we have rule promulgated by October of this year. And we definitely have to have public comment sections, and we are working to get those scheduled as we speak. And as soon as we have a schedule like Robert's, we can definitely bring it to PAC or email it to CHSDA or the Wednesday calls or whatever, and we'll be able to have that schedule out so folks can come and either we'll be doing in person and virtual, so we'll have multiple opportunities to see what that is and have input to help co-create that rule.
Matt, can you make sure I specifically receive that as well? I think I get most of the CHSDA communications, but not all, so that I can also get it with this group and the commissioners.
Yep.
And I know there's some others on in this group who may not fall in those categories.
Yep.
Do you have any sense of when that might start, or is there anything folks on this call might be able to do to help kind of facilitate some engagement in those?
As soon as I have dates, I'll release them first. I mean, you guys will be the first ones to know for sure. So I don't have anything other than that to share at this point.
Any other questions, or I get even comments on the HCPF settlement agreement? Okay. And I stole a screenshot of your timeline, Robert, so I'll include that in the follow-up from this meeting as well. Jamie.
Hello. Hi, Robert. Within the 1038, there's also an implementation team requirement that I know that there were some, like, are we doing it? Are we allowed to do it? Was the AG gonna come back and say that we can't have that implementation team? Just wondering where that discussion is at, and if you're thinking of how that implementation team is going to be formed and what that looks like.
So the implementation team is one of the committees we are talking about here. I reworded it because it was confusing. It's a partner advisory, but it's really the implementation advisory committee. We are working on that. When the governor signed the bill for the implementation, he did submit a signing letter with it, saying that there would have to be some changes to the authority of it because it violated federal regs. So it will still exist. It will be advisory to the department and the project. It just won't be an official authority, oversight authority. Because the feds don't allow us to delegate that.
Thank you. I think that if I recall, the discussion was around the feds not allowing HICPUF to delegate fiscal authority. And I don't believe in the bill we included fiscal authority on the implementation team.
Well, on one of the teams you did, it said fiscal oversight. Yeah. So both they'll exist, but they'll exist in an advisory format.
Okay, thank you.
Mhm.
Hey, Robert, sorry, I don't know where the hand function is either. Ellen Stern with Children's Hospital, just a question, or maybe this will come up in the quarterly updates on 1038, but I think a timeline, so we all understand. I think many of us have general sense of like, so you're having the meetings in August, then the legislature gets the budget request in November. Like, how do these all kind of interact with each other, the rulemaking? A timeline slide or something, so we all understand, like, you all are doing really great work, and just where we can plug in and where there's overlap and where the agencies are working together might be a really beneficial thing for all of us to understand. And I think we all want to be supportive of the conversation and provide feedback at the appropriate time so that we're not all asking you the same questions.
Yeah, and we do have a rough timeline, but we're still working on it, right? This year is about creating the implementation plan, which is part of creating the timeline. So, because things don't lap very well, because February is well past session and things like that. So, I will talk about the presentation about a phased rollout of the work and what our high level phase workout. And
Fair.
Yep. And then Katie, I don't know if you want me to do that presentation here next Tackling Barriers meeting too. We can do that as well.
That sounds great to me. I don't know if any others have any. I guess if you feel contrary, speak now. Let's plan on it. It's a date. Okay, and then Matt, anything you'd like to share from the BHA about the Children and Youth Implementation Plan?
Yeah, any chance I can share my screen also, Katie?
Yes.
Awesome.
Oh, that button is being weird. Okay.
All right, let's see how I do. I think I got it. Hoping you can all see the slide deck. It just says year one accomplishments. Yes,
Any way you could zoom in a touch?
probably. I'm gonna do 100. How's that? It's better or worse? Trying to look at faces.
Yeah, that is better.
All right. So Children's Implementation Plan, we are 8 months into year one of the 5-year plan. This is actually 8 now, but when this slide was done last month, we were 7 out of 19 action items. These are 19 year one. We only had 19 tasks or action items due year one. We had 7 done. You can see how they're spread out over BHA, CDHS, and HICPUF. So these are the actual tasks that were completed. And then this is obviously the number we have left to do. We are currently on task to complete all year one items. So a huge thank you to Robert and his HICPUF folks and all of our CDHS folks, either on the call or not on this meeting, but doing a lot of work around this. We appreciate that. Year two, things start to get very, very busy. Again, we only had 19 year one. We have 50 initiatives kicking off year two. Some of those initiatives are not year two and to be completed year two, but will kick off year two and to be completed maybe year 3 or 4 of the plan itself. So we also did bring on new agencies. When the children's plan was originally drafted, we had 9 different state departments involved and who committed to doing tasks around improving access and the quality of children's behavioral health. We currently have 13 different state departments, so we've added 4, and these are state departments that wanted to come on. Just that they're doing work around kids and access and stuff like that. So we added those folks. And then also the Lieutenant Governor's office, they had 2 different like departments, right, or groups. They've also joined the plan. So we'll have some new folks and some new agencies joining us. So really excited on that. I think I see it, but I'm not a huge zoo fan, and I think it's because I lose everybody's face here. Heather, I think your hand is up, and that's literally all I see.
Got it.
Yes, exactly.
Okay.
Matt, I had a couple questions about the deliverables on here, the 7 that you all have as completed.
Yes.
So the first one under CDHS and BHA, technically, having standardized room and board rates across all agencies. I thought that was not supposed to happen until this fall and was not completed just yet.
For QRTP, we have rates. I believe we have rates, and that's just for QRTP.
But not the part of the bill of 1038 paying for room and board for Medicaid non-child welfare kiddos. Yeah, correct.
That is in contracting and will be completed by fall of this year. So it's a matter of the contracting pieces. Yes.
Yeah, okay. So when I read that bullet point, that's what I like think of. So that's the piece I was confused if it was completed or not. If there's any way to clarify that for folks, because I know lots of counties have been asking about it and providers.
Yep.
The second one so for crisis resolution teams for BHA to increase awareness to emergency rooms and crisis stabilization units across the state, how are you measuring whether or not you increased awareness?
Yeah, so our CRT team staff have actually gone out. So they're in 21 counties, as folks know, and 1 city. And they have gone out to hospitals, medical centers in those regions, especially ones who hadn't made any referrals or hadn't utilized either CRT or crisis stabilization beds in the past, to make sure that those folks were aware. So they kind of went out, and you can go to the website and see which counties. If you don't know, you're probably not one of the 21 counties, unfortunately. Hopefully you do know. But they do a great job of listing it on the website on which counties those are in the city. So yeah, they actually went out to the medical facilities and did the awareness piece.
Sorry, Matt.
I'm curious. Oh, sorry. Go ahead, Katie.
I just wanted to clarify. Is there a CRT page on the BHA website that you're
There
referring
absolutely
to?
is. Yep. Crisis resolution teams /Colorado will take you right to the page. It'll show you the regions they're at and all of that. Some good information on there.
And just sorry, one more on that one, Matt, to follow up. Will the children and youth implementation plan have any metrics assigned to any of these? Because I know the website has been in place for CRTs. I know that BHA has been different places to communicate it, and I still have heard anecdotally, lots of folks don't know about them on the hospital side or just on the other crisis side to refer families. And last time, I believe the HRCC had a presentation about them.
Yep.
They mentioned that a lot of places were in wait lists or not, and not seeing a lot of referrals where they would expect to in some communities. So I'm just trying to get more information of like, what are the metrics for success, and like, how are you all planning to try and report out some of it? You don't have to answer it now. It's just something that would be helpful.
Yeah. So yes, we are looking at better metrics for the plan in general, right? So one of the key things of the plan we're doing for year 2 is really reformatting around a system of care, right? And utilizing the components of system of care and taking a lot of the tasks in which are currently organized around priority, right? The immediate priorities, which was really important. It was great to kick us off and move that direction. But as we move towards kind of a comprehensive set of services for all children and youth, how do we measure success? I think has been really big. So having those conversations, also sharing those conversations across agencies, making sure that we're measuring the same things that maybe our CDHS partners or HICPUF partners are doing that way too. So if we are seeing success or not in an area, making sure we're all using the same metrics. So those conversations right now are ongoing. I will say we just launched Performance Hub, and that's where a lot of this stuff will eventually sit. So BHA Performance Hub, another website. There is data out on that, but we'll look at that's likely where we're going to end up hosting this stuff. So there's not multiple sites or multiple dashboards. I can't. There was other hands. I saw them go up, but I can't see people.
Jamie is next. I got you, Matt.
Thank you.
Hi, Matt.
See people. Hi.
Oh, man, you did. Okay, go to the first bullet on the left-hand side of your screen.
Yes, ma'am.
And it says that the state agencies are going to come together to, I can't see it anymore. So
Yeah, I can go back and share. Sorry, I was just trying to see faces. You're
okay.
fine. Let me do that.
But it basically said that they were going to, the state agencies are going to have their teams review the 2020 memo on screening tools and collectively determine an avenue to streamline. So that's completed. So what is the avenue that they've determined to streamline screening? Is that the CANS?
Yes.
Okay.
So utilizing the CANS and the independent assessment. Yeah.
Okay. And so everybody's on board with that.
Yeah. I mean, again, rule hasn't come out. We're not, but that has been the decision. So we need to then start moving that direction. Correct.
Okay. Thanks.
Hey, Matt, I just have a similar question on the, under the BHA, the capacity for crisis stabilization beds. Can you talk more about that? Because I think from children's perspective, and I asked Katie and Heather if we could talk about this population specifically, we continue to really struggle with delayed discharge for kids who have co-occurring disabilities. And you know, we have all collectively done a lot in that space in the last few years, but it has felt like the funnel is getting smaller and smaller for options for that population. So I'm really interested to better understand what that means around developing capacity.
Yeah, so really looking at, and this was at a point in which we had legislation going forward on CRT also to make sure we could ask for what this would look like statewide, and not just CRT, but crisis stabilization beds also, and seeing what that could be. I do know our crisis team and the folks did an analysis to see how many beds we potentially would need and get funding for. We did not get funding, right? But specifically to the delayed discharge, I can't speak to that as far as to what this would look like. But we definitely do need more crisis stabilization beds than we have. And they had better numbers and metrics, and I don't have those in front of me.
Right. Ideally, if we're getting kids before they even need an inpatient stay, that's what I think we're really interested in too. I think I just want to piggyback on what Heather was saying in terms of understanding the metrics. I know so much work is going into all of these, but we have very little visibility into it, and we all want to be really good partners and understand and plug our patients and families who can benefit from this amazing work. So to the extent there's additional, thinking about how you're describing these tactics and how we can utilize them, how we can support them, it would be really helpful to have that. I know it's being somewhat built out on the Performance Hub, but we're all part of the implementation plan too. So I just want to give some credence to what Heather said around the importance of those metrics and really understanding what it means. So appreciate that.
Is there anybody else before I stop sharing screen? Katie?
No one else with their hand up.
All right, perfect.
Matt, I had a slightly unrelated question, and you alluded to this a little bit, but I know there was some talk of kind of revamping the implementation plan, not so much the actual action items, but just kind of like how it's displayed, and maybe there was going to be a dashboard or something like that. Can you share with us where those efforts are?
Yeah,
And if there's
so
an opportunity to plug into that as well?
one of the things we're going to do, because we do have new partners joining us, new tasks doing, to add on to the plan. We also have completed some tasks, right? So finding ways to message what that could look like, and then again, reformat. It's not redo. Like redo feels like we're starting from scratch, and we're absolutely not doing that. But reformatting it in a way to bucket the tasks around the some of the components of system of care. So prevention, screening, assessments, care coordination, crisis stabilization, all of those. Just kind of seeing what that could look like. Getting back to then what Heather was saying and other folks were saying around metrics, and ideally we could measure or find a series of metrics to measure how we're doing at each of those components. Right. I mean, that would be the ideal state, is measure component progress or lack thereof, or a gap in the system that way. So we just started kind of reformatting what this could look like. The first things we're going to do, obviously, as soon as we get something drafted, is share it with all of our internal partners. So make sure that the other state departments and Lieutenant Governor's office agree with the formatting and the tasks and things like that. And then we will have it out to for public input late fall. And I say that as a timeline because I really want to have something. I want to have pen to paper done, finalized, and published before obviously 2025, so that we can, that's because that will be year 2. January 1 of 2025 is year 2, and we'll be doing the thing. So it sure is nice to have a drafted public plan out before we're actually doing it. So look end of fall, and then we'll have comments and draft language to look at.
Okay, maybe that's something we could also discuss with this group, and get feedback on when the time's ready. Heather Dorosco put in the chat, the bullet under HCPF, does that mean that adding mobile crisis response as a Medicaid benefit is completed?
Robert, do you want to speak to that? It was track the progress of adding mobile crisis response as a Medicaid benefit.
Sorry, which one is adding as a benefit? I'm sorry, where are you at?
Right. It was just track the progress of adding mobile crisis response as
Oh
a
yeah,
Medicaid
it is a benefit. Yeah, so we're just tracking it. It's up and running, and it's billable.
And Kelly, I know you were, I think in the car maybe, and then transferred over to your office. Thanks for being here. I don't know if you have anything else you want to share on the implementation plan. Matt's doing a great job though, taking all our questions.
Yeah, I've been listening the whole time. No, I don't have anything else to add, except to go back to saying we are close to having dates, locations relating to the rules when you all return. So we'll get that out. We had to rework some of them, or they would already be out. But we're coordinating, so we're not in some communities multiple times, like with HCPF going out there. We're having community conversations with our new commissioner. And so we're just having to adjust some dates to make sure people aren't like, oh my gosh, how many state people can we have each week? But we'll be for sure able to share that. But no, I don't have anything else to add on the plan or any of those pieces.
Thank you. Anything else on the implementation plan? Okay. Molly, are you with us? Hopefully.
Yeah, can you hear me?
I can.
Great. I am still just stuck in traffic, so it's going to take me a little longer to get back to my desk. But I am happy to give a verbal update in the meantime, if it's helpful, just to start on the CDHS sides of 1038. And then I also have Logan Ellett with me, who covers our wildly important goal around high acuity and can talk to some of our metrics too. How does that all sound?
That sounds good to me, if you're okay doing it from the car.
Yep, just give me a little grace as I multitask here. So a couple different things that I just want to give an update on for 1038 on the CDHS side. We have That bill, as you'll recall, had three main buckets. One was around provider rates, one was around quality assurance for residential providers, and then one was really around system of care. And I heard Robert on the phone already giving an update around the system of care pieces. So I'll do the other two to start. One is there were several items in the bill that really revolved around adding more money to the system to support the needs of providers who are serving our young people with high acuity behavioral health needs. And the first core piece really was continuation of a number of different pilots that we originally started with ARPA funds that have proven out to be really, really successful in terms of opening up spaces for kids who otherwise wouldn't have places to go in Colorado. Southern Peaks is one of those facilities. We have several state contracted beds at Third Way. We have several treatment and professional foster care beds as well. All of those pilots that we started with short-term funding that we were worried about having the funding run out were all continued with general fund resources in 1038. So the first update is that all of those contracts are being extended, which is wonderful. We are just in the process now of finishing spending down all of our remaining ARPA dollars. We are currently projecting that all of our ARPA money is going to run out in November for those pilots, which was just about a month short of where we initially anticipated it running out. And we have plenty of general fund to be able to continue. So if you are a county that's already using some of those state contracted beds, you will still have access to those state contracted beds, which we're extraordinarily happy about. The second piece that we did, so under this model, we had, instead of having all of our counties and our RAs individually contract with folks or residential providers for the placement of kids, one thing that we did through this pilot is have the state directly contract. And then what we did in addition to having those contracts is that the state with our specialists controlled admissions and discharges and triage the number of young people who were referred for those beds based on level of need so that they could really match the kids with the highest level of need with any open beds. In exchange, we paid an incentive above and beyond what the daily rate was to allow us to really do that matching, which in turn gives resources additionally to providers who otherwise might not have the right staffing ratios, for example, or the right resources on hand to be able to support those kids. So what we did in 1038 is we actually expanded that pilot and we got funding for an additional 32 beds that we're going to be bringing on board under state contracts at the QRTP level. Those right now, those contracts, we're in the RFP process. So the RFP has been written and we're going through procurement and we'll hopefully have that out the door here I'm going to say the next month, most likely, depending on the timing of procurement. And so we'll be working to get providers on board to be able to do those state contracts with us and really hope to have those 32 beds additional in terms of state controlled admissions and discharges by later in the fall. So that's kind of the first piece. The second piece was around rate increases, and I heard some of the conversation around whether those rate increases are active. One thing that I do just want to note is that the bill itself doesn't go into effect until 90 days after the end of session. So this is the month that we actually get money to be able to do that work. So in terms of rate increases, you wouldn't have seen those yet, especially on July 1 at the beginning of the fiscal year, because the actual resources tied to the bill in the first year don't actually come to us until mid-August. So later this month, we'll see a memo go out actually that adjusts our QRTP rate for counties that are placing kids at a QRTP level of care, which will go up from $320 a day to $425 a day. The incentive program that we're subsequently contracting for those 32 beds, that will be an additional $233 for a day for any provider that comes under our state contract. So it is a pretty big bump for QRTPs. All of the QRTPs regardless will go to $425. And then you can go up into the mid 600s per day if you do enter a state contract. So again, later this month for that rate increase. The other two pieces that I want to talk about briefly are around quality assurance, since that was always a big thing where we got a lot of feedback from counties around how do we know if our providers even do admit young people, if they're able to serve the youth. So we have 3 different components that are things that actually we were luckily able to start doing well in advance. And the first one was around development of a clinical care team that can be on hand to provide technical assistance to our providers anytime that they are working with a young person who may have a slightly different clinical profile or may have more complex needs than what they're used to. And our clinical care team is going to be a group of 4 licensed clinical social workers overseen by a part-time psychiatrist that will be able to deploy to any provider that is looking for support in terms of wondering how to treatment plan around and respond to the needs of a young person who's just maybe has different needs and a little bit more acute than what they're used to. We are currently writing all of the position descriptions to get those FTE on board. And so our hiring process is just kicking off as we are getting those resources this month. The second piece is really around establishing quality standards and creating a performance management and outcomes team, which this is one that we were able to actually do even in advance of the bill passing. Once we had a good sense that it was in fact going to give us ongoing resources, we kind of kicked into high gear. So we currently now have a performance management and outcomes team that's 6 people in the Office of Children, Youth, and Families that are outside of licensing and monitoring functions that are purely focused on implementation of trauma-informed care plans and continuous quality assurance for residential providers. They've created a 3-phase program essentially to work with individual providers around how to really level up quality of care depending on the residential provider's goals. They actually to date have already worked with all of our PRTFs in Colorado, and the next level is they're starting engagement now with all of our QRTP providers. And then after they get through that next cohort, they'll be working with even some of our foster homes, day treatment programs, et cetera, to really cover the whole spectrum in terms of providing quality assurance and helping to enhance quality of care. Again, it's not licensing and monitoring. It's really a more supportive mechanism that's disconnected from any sort of rules or oversight assurance. We still have licensing and monitoring, but it really is focused on technical assistance, coaching, and quality assurance. The last one that I will add, and then I will pause, is our Provider Training Academy, which we have some really good news on. So the bill also in 1038 mandated that we create a training academy for staff members who work at residential providers, recognizing that many times our residential providers are hiring young people who are early in their career, have maybe never worked in residential, don't have necessarily behavioral health backgrounds, and may not know how to react in terms of de-escalating crises or responding to young people who have certain behaviors. So what we did in the bill was that the bill requires us to create a training academy that all residential providers can use to help train and develop a workforce pipeline so that all people who are staffing our young people in residential care have the same training curriculum, very similar to our Child Welfare Training Academy. So that I am super pleased to say is actually all done. We have finished the entire Provider Training Academy. We contracted this time about last year in hopes that we would have ongoing funding, but actually have finished designing the whole curriculum. We've recorded the entire curriculum, and we're in the process of uploading it all onto a learning management system for our providers to be able to engage in. We're then going to be piloting that residential training academy with a set of providers starting in mid-September. So just about 6 weeks from now, we'll be kicking that off and then taking feedback and really refining the program as needed. So really, really excited about that because that's a piece that I know residential providers have asked for a really long time, and should really, really help in terms of the ability to serve some of our young people, especially where there have been staffing barriers before. So with that, let me pause and just see if Logan, if you want to jump in as I transition to computer and talk a little bit about metrics, because I know I've heard a couple conversations about, well, how do we know, how are we measuring the success of this? How do we know it's working? CDHS actually does have a wildly important goal this year that we are providing monthly updates to the governor's office on. And those reports are public and really encourage folks to continue watching those because it will have monthly updates on many of these activities, and including and will also include measurement of some of our wait list data to show how many young people are waiting for high acuity beds who are not yet served, so that we can see if we are making an impact in being able to serve more kids in this level of care. So Logan, are you online and able to jump in at this part briefly?
Yes, I am. Hi, Molly, and hi, everybody. Thanks for having me. Molly covered a lot of what I was going to mention, so thank you for that, Molly. In terms of metrics, like she mentioned, we're measuring for the governor's WIG 5 of these independent goals, 4 of which are a part of 1038. The wait list that we're measuring and trying to reduce are QRTP, PRTF, and our Friday Child and Youth Consult list. Right now, because
Oh,
wait lists are
Logan,
not.
and I don't, hopefully this is true for others, but your audio just cut out. It looks like you're off mute, but
Uh-oh,
oh, that worked.
can you hear me?
Yes.
Okay, sorry about that. In terms of measurements, we are tracking waitlist numbers for all QRTPs, all PRTFs, and the Child and Youth Consultation State Staffing Waitlist, which is our Friday list, including youth who are stuck in inappropriate settings. Right now, we just developed Google Forms to track that information because I think, as you all know, our providers don't just take child welfare involved youth or youth referred by RAISE. We have a lot of private placements and private folks who are awaiting on a wait list as well. So we've developed a system to track the wait list numbers. And I was just writing the WIG update this morning, actually, for July. We do have crystal reports that are tracking all of our specialized foster care beds and any fluxes we see in terms of increases or decreases in specialized foster care, which is therapeutic treatment and professional. And then the PMO team, the Performance Management Outcomes team that Molly mentioned, they have their own tracking systems of how they are working to implement that clinical care strategic plan, which is specifically for the governor's WIG around working with QRTP and PRTF providers this fiscal year around their trauma-informed care plans, their discharge plans, aftercare, et cetera, and in conjunction with that clinical care team that Molly mentioned. And luckily, our unit, Provider Services, got a pretty giant head start on this, which we're very thankful for. And so a lot of these efforts have been moving since last year or so. And so we're just kind of refining practices, which is why Molly mentioned the training academy. We are excited to get to pilot that come September. And the goal, again, is to train QRTP and PRTF staff first. We're trying to start at the highest levels of care and trickle down. Really, all of these efforts aimed at those higher levels to try to move children and youth through the continuum and not have kids who have to be assessed for lifetime limits or kids who are stuck in PRTF for over a year. And knowing that these are stabilization facilities primarily. And so the PMO teams will be working through a lot of that and providing a lot of that data as they do the work with our PRTFs and QRTPs. I did want to mention a couple other things related to high acuity bill and some of the efforts we're making, which a few of you are involved in. We all are also tracking placement denials through the Universal Placement Referral Form pilot that is going on right now. And a handful of counties on here are participating. And so thank you for that. And our check-in meeting will be September. The pilot ends December 1st or 2nd. And we'll kind of assess all of the data that was collected from those 9 pilot counties and 2 RAIs who are piloting it and all of our providers to figure out next steps. And we think that data will really help our provider services unit to improve the placement continuum. And did also want to mention that ahead of, we kept our fingers crossed that 1038 was going to pass, but ahead of that, we added a lot of language into our rule updates that we've been working on, or really for 10 months now, bringing them to SubPAC next week to include enhanced quality of care, quality assurance practices, trauma-informed care plans, really all of the components of the PMO team, soon to be teams, are in our rule drafts right now. So we are actively moving forward in the process and looking forward to kind of refining it as we start to implement. Any questions Molly and I can take?
Yeah, thank you for that. And sorry, Mary, to jump in, but we did have a question in the chat from Becky Miller Updike with Kafka. Do we know when the Medicaid room and board will kick in?
So I think, and sorry, I just got home and I have very excited dogs now. So for Medicaid does not pay room and board. Medicaid only pays treatment. So what it is there's a behavioral health administration fund that's going to start kicking in room and board. And that's what Matt was talking about earlier on the call in terms of going through that contracting process now to be able to get that up and running late fall, early winter to be able to kick in on the BHA side. Medicaid will still be only doing treatment, but because Medicaid doesn't cover room and board, what the bill did was really supplement it by creating a room and board fund with the BHA.
Becky, did that answer your question?
Yes, it did. Thank you, Molly.
You're so welcome. Mary.
Good afternoon, everyone. I just put in the chat, I was curious listening to Logan about the reports that you're talking about that you're sharing with the governor around the WIG. And I know that counties are collecting very similar data. It would be really nice if we could have an opportunity to see that data on a regular basis, compare, contrast, answer questions, whatnot. And I know that CDHS does a great job of sharing information with counties, like on a weekly update and things like that. So perhaps there might be an opportunity for some increased communication on that. So let me know what you think about that.
Thanks, Mary. Yes, absolutely. Molly and I were actually working on a template that includes all WIG updates to bring to Tackling Barriers to make sure that you all have all of the information that we're reporting on the WIG. The WIG data is published to the governor's dashboard, but it is in such, not in detail, I'll just say that. And so all of those specifics will come in those Tackling Barriers updates. And then Molly and/or I will be present in your Tackling Barriers meetings outside of those updates to begin to give you any extra information. And then there's one data report that we run from Trails that we may be able to make public for you all as well, because you all can access those therapeutic treatment and professional homes and Trails as it is. So yes, you will all be getting that information.
Logan, I'm sorry, are you at least able in the meantime, because I know we talked about those quarterly updates, but are you able to share what it is that you share on a monthly basis with the governor on the WIG, or is that compiled on a website somewhere?
So Katie, I just put that in the chat in terms of the performance plan that we have for CDHS every year. And I believe this is the one, I think it just got published actually, that has our high acuity goal. So you can see, yes, it is in fact. So that document that I just put in the chat is the first document of the year. It starts on a fiscal year basis. So we'll be providing our first monthly update here at the end of the month to the governor's office. But that's the public one for now. That just shows you what we are tracking essentially.
Okay. And sorry, I think I may have confused myself. Do the WIGs fall on the fiscal year basis for the state or on the calendar year?
Fiscal.
Okay. And because this was a WIG last fiscal year as well, right? So it's a continued, or
yes, it's not exactly continued. So last year what we did is we were tracking by number of beds. And what we saw was when we tracked by number of beds, actually, we blew the goal out of the water, but we saw that the problem was still happening. So that told us that our metrics actually weren't the right way to measure. So last year, what we were tracking on was therapeutic foster beds, PRTF beds, and QRTP beds, and specialized foster care broadly. And those ones, we did see that really big increase, but because we lumped them all together as just beds broadly, that didn't solve the problem because we had plenty of beds, but not the right necessarily type for all the young people. So this year, what we did was we revamped it. It is a continued WIG, but instead of measuring by number of beds, we're measuring by number of kids on wait lists for high acuity beds. So that's going to give us a better sense across wait lists, how many kids are actually accessing the right types of beds versus how many are waiting still in either county offices or emergency rooms or other inappropriate settings to track whether that number is in fact going down.
Gotcha. And sorry, I keep dominating the conversation. And I'm just now opening up this link you put in the chat. Thank you for that. Is there like a final report? I mean, I know you blew it out of the water and clearly you did because we have 1038 and all of these beds, but is there kind of a wrap up of that we're able to see as well?
There is a wrap up. Let me see if I can find it. I will paste it in the chat if I'm able to get easy access to it quickly. We do have an end of year report. I don't know if it's been published yet since we just submitted it maybe a week or so ago.
Oh, okay. Thank you. Heather.
Thank you so much, Molly and Logan, for all of that. It's really helpful. I have two questions. I'm sure you're not surprised. The first one is, I'm wondering for the CDHS contracted beds that are expanding at QRTPs, so 32 more QRTP high acuity beds. Does the RFP aim to address some of the remaining gaps that we're still seeing providers deny around today, such as the treatment regarding if there's any like sex offense treatment needs, or if there are those co-occurring disability treatment needs that Ellen was talking about earlier, oftentimes with like a medical need, our main gaps that are still there, but does the RFP that's going to expand those bed specifically try to address some of those?
The answer is sort of, but that isn't going to be the only thing that will fix that problem. It still has to be a variety of, so I know that I listed like 20 different initiatives, and the reason I listed 20 different initiatives is because if this were something that we could just fix with an RFP or a state contracted bed, we would have fixed it a long time ago. It is really a multifaceted thing where for each individual young person, there are really different needs. And that means that we do need a suite of different program options. It isn't, I would say, as simple as just contracting for high acuity beds at the QRTP level. Our hope is that that helps fix some of the problem, because we know there are a lot of kids who assess as needing a QRTP level of care specifically that are currently denied by QRTPs because there's insufficient daily rates and insufficient incentives. So we'll fix part of those for kids with QRTP assessments. However, it also will not necessarily on a kid by kid basis fix all of it. If you have a young person, for example, who's denied because of X, Y, and Z, it really is an individualized planning piece where we have to look at, is professional foster care actually the solution? Is it PRTF? Is it QRTP, but a very specific type of QRTP that specializes in this particular piece? The goal is that we are trying to expand across the full continuum to make sure that there's a full suite of resources at every level of care to serve kids based on their individual needs. We found that it isn't viable really to be able to start up just like a sex offense specific program, for example, because one, that might be really hard for providers to do, and two, that might not be good from a milieu perspective. So it really is about making sure that we have providers who are supported on an individual basis, kid by kid, and matching them based on having more resources, more workforce, more funding to be able to support programming, clinical care specialists from our team who are going to go in and be able to support how to keep the kids safe. All of those things have to happen in addition to treatment foster care. I know this is going in a roundabout way where the answer is unclear, but it is to say this is a really hard problem. And what you are mentioning can only be solved through a variety of different things that we have to do simultaneously. It helps, but it isn't the full solution. And I see Robert has his hand up too, so he's probably got more to add than me.
Yeah, I mean, two things. One, this is part of the reason why the state is building a state-run PRTF, right? For kids that we've run out of options community-wise, have unique needs. And two, why our system of care that we'll be presenting about in August is intensive in-home service focused, right? So those are two reasons big reasons why we're focused in that direction. But the impetus for the state-run PRTF that's being built was having children with sex offenses, arson, hard to place into community providers because of risk to others. So I just want to throw that out there. I know it's not coming quick enough, but construction and building and the fun that is.
Thank you. To any extent that, all those various pieces do start helping with some of those gaps, that's definitely something like we love hearing about. Communication around it is super helpful. And secondly, so I was going to ask about, do the quality standards that the performance management and outcomes team is looking at, or does the provider training academy address discharge planning at all? Because I think we're still really finding major challenges around good quality discharge planning that starts from the time of entry when a kiddo goes into a residential setting, and then really sets them up for success to a step down option. So I'm just curious if either of those initiatives will aim to help with some of that. Thanks.
Logan's off mute. I'm going to let her take this one.
Yes, thanks, Molly. I think we're tackling this again in a lot of different ways. There's just not a silver bullet that would solve the issue with discharge planning. So like I mentioned, we have added this into the expectations for the revisions to the provider rules that are going to subpack next Thursday, around their expectations to start discharge planning at intake, so that it's part of the whole process of that youth being in that facility. It's also a very direct focus of the PMO team. They have really specific strategic plans built around how to improve aftercare and discharge planning with providers, and they spent all of last year trying to refine a lot of those practices. And it is a component of the 40-hour Colorado Provider Training Academy. And part of what's happening in these next 6 weeks or so before we start to pilot is making sure that all of those lanes that have been identified as pain points in the provider continuum, discharge being one of them, aftercare, treatment planning, trauma-informed practices, physical management, restraint and seclusion, et cetera. Those are all very specific topics within the training academy. And I can reach out to that team and kind of get an overview of those content areas if that would be helpful for this group to see as well.
Folks want to jump in? Is that helpful? I know Annie, you were asking about that. Is that something you'd like to see? I'm seeing some thumbs up. So I will connect with you on that, Logan.
Sounds great. I'm happy to provide that.
Great. Any other questions on 1038?
Katie, you're muted.
Thank you. I was just saying time is flying, but I think in addition to getting these updates on a regular basis, I'm hoping that this group can also talk about, maybe identify some remaining deficiencies and themes we see, things we want to have additional, maybe similar conversations on, or also, maybe at some point work on additional recommendations regarding, those could be big problems we still see. And I feel like some of those were touched on in our earlier discussion, or those could be smaller little things. So I just want to kind of leave it to the group of what deficiencies do you believe still remain in placing children and youth with high acuity needs? Is that too big of a question for a Friday afternoon? Annie, jump in.
Okay, can you hear me now? Good, okay, figured things out. Okay. One of the questions I think I had, and I know we've talked about it a couple times, but part of what I think myself and other individuals within counties have struggled to work through is when there is being discussions about state beds for some of our county kids. We're not getting the feedback or information necessarily back of what that discussion has been or where they're at with the potentially being eligible for state beds or not at times. And I think that makes it difficult for counties to know where they're at in their process, where they're at with their specific kiddo. And so I just wondered about really thinking about a communication structure in order for counties to know when their kids are waiting and for placement, what that looks like.
We both came off mute at the same time. Annie, I don't know if I'm 100% tracking the question. If you're thinking about an individual kid, all of that usually happens in the Creative Solutions meetings where we already are pretty closely usually engaged with caseworkers as we're going through and looking for placement. And we usually do talk there about whether or not there are young people on a wait list and what that timing looks like. If you're asking more broadly about just numbers of open beds, all of our state contracts have been habitually full. We've only had open beds while there were kids transitioning to and from. Yeah, but let me know if I'm misunderstanding your question because I feel like I might be. And Robert, anything you want to add?
So I can give more context. I think, Sean Bross came and presented for us about some of those beds and how that internally that they are staffing youth for those beds. And so, but counties don't know what that looks like or know if their kid is or isn't being staffed. And so that's kind of where I was thinking about that in that space.
So they are, if it's a Medicaid kid, they are staffed at Creative Solutions. They should, that's where the staffing and the case review and the decisions about placement and updates on any feedback from the provider on waitlist. But you're talking about Southern Peaks likely, or one of the beds that Molly mentioned, right?
Well, I think that there was therapeutic level, even of foster care, there was state beds, there was placements like that. And so one of the things that Sean had shared with us is that that is an internal discussion that happens. And my question is, I don't know if that's because I've been a part of many Creative Solutions meeting, including one for a kid for a month and a half. And I don't know if he's being staffed in that internal discussion or not, or being considered for those beds. And so I'm just wondering about that kind of communication structure for counties to know what that looks like, or if there's an opportunity where they are considering that kiddo.
Molly, why don't we take that back to Sean and make sure that they're bringing that information to Creative Solutions so that everybody in the treatment team knows what they're being considered for.
Yeah, I'll make sure. I think this just might be a misconception a little bit. Even on Sean's team for the Southern Peaks beds, which are managed by Amanda Rodriguez, in order to even be on consideration for those beds, a county has to submit to us centrally and initiate that conversation. Those kids would never be staffed without the county in consideration for those beds. So in the management of the program, if you are not hearing anything, it would be because the child is still on the wait list and your county is already likely in communication. But we don't have regular meetings about which kids need to go into Southern Peaks where a county is not already present.
Mary.
On the topic of Creative Solutions, I know you've heard some of this from me early on, but are we collecting any data on the outcomes of the Creative Solutions meetings? Are we doing any quality assurance reviews? I've just had feedback that sometimes some of the state staff are pretty quiet in those Creative Solutions meetings. And I know we've talked about the impact and the outcome of those meetings before, but I've heard some just recent feedback around if there's an opportunity that we have to increase the value or the outcome of some of the Creative Solutions processes.
Yeah, that's a good question. Oh.
Yeah, I'm absolutely game for that. So it is something that I've been talking about with Stacy and Gina in our shop. What would be really helpful is if you all have specifics that I know we've talked about it, but if you could send me something in writing, so we can, so I can follow up and make the adjustments needed to Creative Solutions, because that meeting has to be beneficial. And I know it's not always. I've heard that it feels like a repeat, like every meeting is kind of a repeat. The last meeting, that's one thing we've discussed with my team is that spending too much time getting people caught up. And so you spend 75% of the meeting rehashing old things versus talking about new things. So trying to figure out how we have information and documentation in a way that people don't have to get people caught up to speed every meeting.
Yeah, and I just want to clarify, sorry, Robert, we actually did do this for the child welfare specific part of Creative Solutions. So just want to be clear, because Creative Solutions obviously is not all county kids. For the county kids, we do collect data on the length of time to placement. We collect data on the outcomes for that young person of when they're discharged. And Mary, we actually had a CQI process that just ended maybe 2 months ago, where there were several different focus groups and several different meetings. There was a survey where we got a lot of feedback from counties. I can pull the Jeffco folks who participated too, because I know we had Jeffco on those meetings to provide feedback. And that was all part of a larger CQI process to do exactly what you're talking about.
Yeah, thank you, Molly. I think just sometimes sharing that information helps sort of shore up some of those gaps. I don't know, Annie, if that was something that was shared in SubPac or talked about. I just know that, and so I appreciate that, Molly. I wasn't aware of that, but it would be nice to see if, there's some similar opportunities on the HCPF side from that information as well. And we can always kind of check in, Heather, too, with CHSDA.
Heather, and do you want to pose your question in the chat as well?
I'm trying to talk less. So I like divide it between the chat and raising my hand. Just on that last point, what I put in the chat is, Robert, is HCPF still planning to specifically audit Creative Solutions? And I know you had mentioned wanting to develop some specific training for the facilitators and things like that from phase 2 of Tackling Barriers. I just didn't know, because of resources, if that was something you still hope to do or not.
Yeah, the resources is an issue for getting an external audit, but we did hire 2 new staff members who are participating and getting their fresh eyes, perspective, feedback, and we're using them as a mechanism to get more information in an audit form. But resource-wise, we did not have it to bring an external auditor in.
If there are specific changes you all hope to make from just that more informal process, is that something you could bring back here and let us know?
Yeah, and like I said, something in writing from you all, sort of summer, if you could put what your perspectives are, what you would like to see improved upon in Creative Solutions, if you could send it to me, that'd be great. I can just forward it on to that team that's working on it.
Thanks. And then I raised my hand. I was going to bring up the House Bill 23-1269 data. So, and maybe Ellen, or if Megan is still on, want to talk about it too. I know that we still had some questions about as that data collection was getting stronger, when it would become public, and then how the BHA really plans to use that in a helpful way to look at how we can strengthen things on the hospital discharge side. And then 1269 also had the county data reporting requirements as well. And CHSDA continues to do our own collection that aligns with the quarterly reporting for 1269 through CDHS. I just wanted to get any feedback from you all. Is it still helpful? Are you able to use our data to help inform some of the stopgap setting stuff, and those sorts of things? Thanks.
I think that was for me. Yes, Heather.
I think certainly for the 1269 hospital data and the status.
Yeah, there seem to be a lot of pieces, so I was just trying to navigate. Yeah. So the last data BHA reported out and made public on 1269 was in May. So there is our agenda and notes, and there was a slide PowerPoint done by Jordan Bass, and so there was data reported out at that point. The biggest issue with that data reported out is that was from Q2 to Q3. We went from 51 hospitals who had submitted data in Q2 to 11. Right, so we have data on those 11, and it wasn't quite where we needed it. So I know they're still working on that. And also we had to bump back data collection date from July 15th to the end of July. So we just got the next quarter of data, like just 2 days ago, right? And so we're going to begin analyzing that data also. But that's what we have at this moment. Megan, glad that you're on.
Yes, no, and thank you, Matt. And for those of you I don't know, Megan Axelrod with the Colorado Hospital Association. And appreciate all the back and forth on this. My understanding, last time I had talked to Jordan about it, was the reason there were such a few number for Q2 was the issue with the Google form. And then obviously our request was to find access to the old Google form, because obviously many more people reported through kind of the old form. So my understanding was that there were commensurate amounts of data in Q1 and Q2 because we were able to access the Google form. So we had kind of the full complement of data for Q2. And I think I'm curious to Heather's point, kind of what insights we've been able to glean from that data for the Q1 and Q2 reporting. And then obviously we'll be interested to see the Q3 as well. But I think especially the hospitals who have been reporting are interested to see specifically what we're able to do with that information a little bit.
Yeah, for sure. I also think there's a continuing conversation of, because the data collection ends in October, right? I mean, the bill and all of the data pieces end. So is there an opportunity then to continue to get that data? Because I think that would also provide great insight into, is that something that now that it's built in, we can continue? Is there a value that way? Or are we just going to see a kind of a hard stop? And just for future conversations, there is another, I mean, like, again, 1269 has its own group, and that is, I can put the meeting link in if folks want it, but that is coming up again. And it's also on the BHA public calendar. So anybody who wants to attend and see that data, Jordan is there, and Ryan and Meredith are also there from BHA. So we definitely get it for much further in detail in that meeting on 1269.
No, and thank you, Matt. And I'll just share, I think we're hearing kind of a general level of frustration as we get closer to the end of the data reporting, that they have not seen kind of public reporting of the data up until now. And so that's kind of their mindset going into the question of if it would continue. And so I think to the extent that there are pieces we're able to use kind of and glean some insights into, I think that could help for the ongoing data question and discussion. And of course, happy to partner, and we'll join that upcoming meeting as well.
And sorry to jump in, Ellen, but just going on of that, the other day I was on, I want to say it was the Performance Hub website, Matt, and there's a link to 1269 data, but it took me to the actual bill. So if there is something publicly available that you're able to share, I think that would be great as well.
Yeah. So in this meeting, is a running agenda for this meeting is the slide deck where all the agendas and slides and presentations have been put up. It's also on the BHA public calendar. This is just, I literally just grabbed my calendar for next week when it's on there. So this is the link for our upcoming meeting and all of it's none of the attached documents and pieces that way. That would all be on the public calendar. But yes, so
it's also linked through the public calendar.
It's on the public calendar, yes. And like I said, that was one of the conversations around 1269 data. Is that something we should be working towards adding on a performance hub? Because that is how we're going to be able to share a lot of our data going forward. And does it make sense to do a lift like that when we know data is going to end in October? Right. So it's almost like if it's not, then we can build that in, but there's a lot to build in. Okay. So that is it better to just report out in this group?
So Matt, we passed that bill and the expectation was that it would be posted online. I just pulled the bill. It's got to be posted on a website that the BHA hosts. Yep. I don't think that having it in a meeting note from, a few months ago is going to be adequate. The idea was we could all use this information. We're all working in this space. But I think there's just a couple people that have access to the information so far. The legislature really needs this information so we can all be advocating for resources or for system improvements or whatever it is. And it's really disappointing, to be totally frank, that almost a year of reporting, we have no real insights into the trends unless you attend these meetings. The whole goal was transparency. So I'd really encourage it being posted as soon as possible on that webpage. Like,
I'll chime in to say it's on a path to be posted publicly with Performance Hub. That is happening.
When is that happening? Since as Matt says, the law only requires that hospitals report in until October.
Yeah, we can put out the schedule for that, but we're working on the internal schedule on the releasing of it.
Okay, because I was told
Down
April
there
and then I was
detail,
told end of July and now we're at August and the reporting ends in October. So that'd be really helpful.
Yep.
BHA friends, just given this discussion, would maybe setting aside some time at a future meeting to go through that data and what you've shared or what you have collected, is that something you might be willing to do at a future meeting?
I mean, I guess my first default would be come to the meeting that we have for 1269. I mean, everybody's invited. It's a public meeting, and we can definitely get into whatever we need to there. Happy to get into it. So yes, we will be doing that. And then we've also included, this meeting will continue to meet, or this group will continue to meet quarterly. So we have, I believe it's on the public agenda for a public meeting for another meeting after the August meeting in 2024 also. So we're scheduled out at least quarterly through the end of 2024.
So I was hoping to kind of, and I think we had great discussion earlier about the settlement agreement and the implementation plan in 1038. I was hoping to spend some time kind of having discussions like these about what are items we should be talking about in the future. And it seems like we've possibly addressed some of those, but I think maybe having some additional time at a next meeting as well would be helpful. So I'm just trying to keep an eye on the chat. Because, in my mind, detention is also a part of this issue. We talked earlier a little bit about discharge planning. That seems like something we could spend some time discussing and maybe learning a little bit more from our provider friends about. I'm going to skip over the charter actually, just because we are kind of short on time. But just logistically wanted to check with you all. Is it helpful to kind of schedule these meetings via a doodle poll, just kind of as folks are available, or are folks would be willing to say, like today's obviously the first Friday of the month, are folks willing to say the first Friday of the month from 1:30 to 3, and maybe we need to actually make it until 3:30 and make it a solid 2 hours? Is that generally a good time? Do you have a preference of which scheduling approach we take? Regular occurrence is better. Is this generally a good time? I mean, obviously you're all here, so you're able to make it, but.
Yes.
Okay. Thank you. Appreciate it. Okay, so maybe let's plan on that. And I realize that I failed to do so, but we'll do a call for agenda items maybe 2 weeks in advance as well, just so we can line up speakers and whatnot as necessary.
Can I maybe put in a plug for the next conversation or a separate side conversation? I mentioned at the top of the call that we are continuing to work with many partners on this call with the IDD population and trying to find the appropriate services and supports in the community for kids who need them. And I believe CDHS, there was a state call today and Renee was on the call. Our director of social work had to drop off of this conversation, but she had asked if there was an opportunity to have kind of a convening around the current work in progress around the NSC services at Fort Logan, for example. Like, what's the status of Laredon? What are the trends we're seeing there? other, intensive in-home services and opportunities there, just kind of like what all the work streams that people are working in for the IDD population, and have the disability advocacy groups who often support these patients and their families part of the conversation as well. Are folks interested in that type of convening and brainstorming and problem solving, thinking about maybe possible policy revisions and or funding needs in that space? Would be welcome to either contact me, or we could start the conversation next month. But I think given the legislative calendar, we may want to meet sooner than in a month. Thoughts from my state partners or anybody else who's on the call?
And we're happy to just however we can. It's not, Katie, that's, I think, for you to decide.
You broke up on my end. I'm sorry, Robert.
Yeah, the second part.
Well, Katie, I think it's for you to decide as far as how you want to do the agenda.
I'm not sure all the groups that are part of that community are on this call is my only concern. And I want to make sure, like, groups like CCDC and groups like the ARC that, worked on some of the past, CHIRP waiver things like that. Like, how can we all be getting updates about work and then thinking about possible needs that remain in that specific population group?
I do wonder, though, if we should keep IDD and complex behavioral health different conversations. I get that people with IDD have complex behavioral health, and that should be addressed. But there are a lot of different parties, even on my end, like that's really Colin and OCL and all them.
Yep.
It's almost should be a separate.
That's kind of what I was thinking.
Yeah. So I would reach out to Colin.
Okay, Colin at HICPUF.
Yeah.
Great. And then Molly, just a heads up, I think our Megan Cook pitched this to Renee as well. So we can follow back up with you and her directly if needed.
Okay, just let us know how to help.
Okay, thanks.
All right, well, thanks everyone for being here. I think just give some thoughts to future discussions and everything we've talked about today, and hope you all have a great weekend. Thank you.